This is a fresh fracture, lateral condyle fracture, and it's a displaced fracture. Seven-and-a-half-year-old patient with a lateral condyle fracture. These are the different options. Should we have the audience response now? Start. The option 4 is selected for this one. So we are going to discuss in the discussion slides on that. This is the second patient. It's having the displaced fracture. What could be the options? Now can we have the voting again? Okay, again most of people, 65 people went for the third option. We have the third scenario, very common scenario in India. That's a patient not treated or inadequately treated, went for the non-Indian, and we'll have the debate on that also. We'll have the audience response on this. Yeah, here it's equal distribution. So a lot of controversies, so we'll have debate on this. So I'll end it here and I'll call for the first talk on the Dr. Mandar for its classification and treatment according to Dr. Shong's classification.
So we'll start off with the basics of fracture of the lateral condyle humerus, and we know that this fracture is a problem fracture. We know that the ossification centers come up at varying ages. We know the mnemonic of Crito. There's very poor standardization of X-rays, especially for elbow fractures, and this fracture many a times gets missed. There's a problem of the unossified bone, which is difficult to visualize without further investigations. And there is a great potential for complications, non-union, avian, etc. And we have to know what to do with it. So I'll start off with a simple ARS question based on this topic. Classify according to the Shong's classification. Stage 2, stage 3, stage 4 cannot be classified, and the most important, don't know about Shong's classification. So we can start off.
5.
So that's why I put this classification. So let's see which percentage is for 5. Alright. So this means that this lecture is quite pertinent, so I'll go on. So I'll start off with the anatomy. We know that this looks to be a very simple fracture, a small fracture, but we should know that this represents a very big chunk of bone which is unossified. We know that this chunk of bone is attached to the huge big extensor mass, and this has a great chance of secondary displacement because of this attachment. We should remember about the anatomy of the lateral condyle, which comes from the posterior aspect, and hence if we are going to do an open reduction, should always remember to stay anterior to the lateral condyle and not go posterior. So this is how the dissection has to be. If we go on to classification, we should know what information we should get from a particular classification. So we should know where the fracture should exit. Is it stable? And how displaced is it? Based on there were three good classifications which were the Mirsky's classification for where the fracture exit is. Milch added the concept of stability to this, and the Jacobs classification about how displaced is it. The Mirsky's classification has 3 distinct fracture patterns. One is exit just medial to the trochlea, through or lateral to the trochlear epiphysis, and which exits the physis medially, which is almost like a low supracondylar. Milch added the concept of stability to it, where type 1 was exiting lateral to the trochlea, which was a stable injury, while Milch type 2 was exiting medial to the trochlear groove like this, because of which the entire distal humeral with the radioulnar group was displacing on the lateral side. The Jacobs classification had the concept of displacement, where type 1 was just a crack, type 2 was a split, and type 3 was with the tilt. But do we have a classification which combines all these features as well as guides the treatment for us? Well, this very good article by Professor Shong from Korea gave us this very good classification which we can use in day-to-day practice. It's quite a busy slide. I'm gonna elaborate it later on. You should remember that these are the common types of fractures which are seen, which are very subtle injuries, and we should always be prepared to investigate further and then classify and plan accordingly. The best way to investigate is intraop, where you can do an arthrogram, and if you're not comfortable with it, you can do an MRI pre-operatively, plan it, and then go ahead. Coming to the songs classification, it goes from stage 1 to stage 5. The stage 1 is when the fracture line is only with a lateral gap, and it has a concept of gap which is less than 2 millimeters in all 4 views, that is AP lateral and the 2 obliques, and it is stable. Type 2 is when the fracture has a lateral gap which is extending only till the metaphysis. Gap is less than 2 millimeters and the stability is indefinable. Stage 3, where the gap is as wide laterally as well as medially, but with a gap with less than 2 millimeters, but which is unstable. Then slowly it starts getting displaced. The gap is wider laterally than medially. The gap is more than 2 millimeter on all 4 views, and it is an unstable injury, but there is no rotation. And stage 5 is a totally rotated fragment with a gap of more than 5 millimeters. So the songs classification is excellent in these stages. Thus, we classify them as less than 2 millimeters and more than 2 millimeters of displacement, and classify them in 5 stages. So in stage 1 and in most of the cases of stage 2, you can go get along with a long arm cast. Sometimes you can fix it in situ in stage 2. Stage 3 and stage 4 almost always require close reduction and percutaneous pinning. Song has extended the class indications of doing close reduction pinning in almost all of his cases, in even stage 5. But in stage 5, it is best to do an open reduction and internal fixation. Thus, I hope, so I have removed the fifth option, and we know that this is between stage 2 and stage 3 based on the arthrogram finding. I'll now take you to the next speaker for the technique of open reduction and close reduction. Thank you.